Good evening, everyone. Welcome to the last day of this heart failure nurses program. We had two fruitful days in the past 4 weeks, where we went through starting from the epidemiology to the management of heart failure in the acute setting and in the chronic setting. Now we'll go to the follow-up of the patients, how to follow up, what are the issues pertaining to that. And then we have a presentation on heart failure clinics. So, and the last and the most important thing will be the post test. So, most of you must have received a JOT form in the form of a Google form type of thing, around 25 questions. So you can answer that, and if you score more than 25 questions, if you score more than 80%, that is 20 questions correct, you will be sent a certificate. You can attempt multiple times. So once you answer, you will know what is a mistake. So you can attempt it again any number of times, and you can get that intended score. So basically, it is not to test the knowledge, but basically it is to drive the points in guideline-directed medical therapy and the information on heart failure, which is an important thing which is coming up. So with these words, I will hand over to Dr. Abraham Oman, President of the Heart Failure Association of India, whose support is very crucial and essential for this program. Over to Abraham.
Thank you and good evening. We have come to the last day of this wonderful certification course. And today I think it's the key part, because discharge, rehabilitation, heart failure clinics, and lastly but not the least, the question and answer sessions. So this is where, at least in India, nurses have the maximum role, and they are the key. So I would not be wasting much time. The first role of nursing professionals, then there will be on cardiac rehab and heart failure clinic. So first session, will start, and Dr. Shantanu, any words? Dr. Shantanu can also put in his opinion. Then we'll go to the talks per se.
I think it is a great initiative. I hope we maximize this very important sessions today. I think everybody should attend it and try to be very receptive. And any questions, we'll be happy to answer. Let's continue.
And the president of TNI, Ms. Annie Kumar, is supposed to join, but they are busy with their conference in Bombay. She will join at any time. I think once in between the sessions, she will address the audience also. So we are expecting her at any point in time. So now we will go to the presentations. Can we have the first presentation? I think most of the presentations are recorded.
Hello, everybody. I'm Dr. Abraham Oman. I'm the current president of the Heart Failure Association of India. And today's topic is discharge planning after a heart failure hospitalization and the nurse's role there. I have nothing to disclose in relation to this talk. So let us discuss certain pivotal issues. So I will divide my talk into two parts. One is the scientific part, which all stakeholders, everybody who treats or part of the treating group, which includes not only the cardiologist, but also the internal medicine, but also the critical care person, but also the nurses, but also the physiotherapist, everyone should know. So let me start. So acute heart failure is a severe disease with poor long-term prognosis. It has been considered equal to cancer or worse than cancer. Why is that? Because by 5 years, 50% of the patients with heart failure are no more. So their 5-year survival is around 50% or less than that. Whereas if you put all cancers put together, the cancer survival after 5 years may be more. That is why it is called as bad or worse than cancer. Hospitalizations are common in the journey with heart failure. Each hospitalization worsens the prognosis. Post-discharge period is the vulnerable period. And again, importantly, but 25% of the patients would be readmitted in the hospital within a month. Within a month. And mortality at this time can be as high as 10%. So sometimes they may not come back to your hospital, but they may go elsewhere. They may have a sudden cardiac death. Each of this is important. And the important things to look and correct in the hospital before discharge are: one is decongestion, initiation, titration, and optimization of guideline-directed medical therapy. Evaluate the primary etiology of heart disease. Identify all contributing or precipitating factors for decompensation. Identify and manage the comorbidities, and identify the barriers to care. How do you know the patient is ready for discharge? What are the things you should know about resolution of symptoms that we should be aware of, like the weight loss, fluid loss, whether renal function has improved or it worsened, whether it's just worsening renal function, or is it worsening it's just the numbers, the creatinine goes up a little bit, but patient improves, hemoconcentration, reduction in BNP. All these things should be, the caregivers should be aware of. Should we also know the clinical features decide stability, biochemical test to decide stability, which includes NT-proBNP, and imaging, which includes echo and maybe ultrasound, sometimes maybe X-rays, but commonest is echo, and the IVC size. So if the IVC size is more than 21 and is not collapsing, that means patient is still congested. So these are the parameters which you look for, and ideally there should be the NYHA class should have improved, but should be asymptomatic or minimally symptomatic. NT-proBNP should have reduced by more than 30%, or the value should be less than 1,500 or 1,000. And the most important thing is whether GDMT is initiated in a hospital. If it's initiated in a hospital, they are more likely to be treated, more likely to tolerate the drugs, more likely to adhere to the medication, more likely to continue the medication, more likely to feel better, more likely to avoid readmission, and more likely to live longer. So what is the Indian scenario? Indian scenario is distressing but hopeful. Why did you say that? Because in Toronto Heart Failure Registry that was published in 2017, only 1 out of 4 had received GDMT at discharge. And by 1 year, 1/3 had died. Whereas when the National Heart Failure Registry came around 7 to 8 years after that, the GDMT number improved to 1 out of 2. So that is improvement, but long way to go. And why is it so important? You can see the graphs here. And if the patient is not on GDMT, was for GDMT, the mortality benefit difference, this cumulative mortality, that's not a combination of multiple things, is huge. That's both in Random Heart Failure Registry as well as National Heart Failure Registry. So that is very important. And when do you call a patient stabilized? It should be off IV inotropes and IV diuretics for the last 24 hours. The blood pressure should be at least more than 90 and heart rate should be less than 100. This is the CSA Indian consensus. But I will come back to the heart rate and blood pressure later in my talk. So how do we prevent readmission? Use of GDMT, patient education about the disease, treatment and dietary interventions. Follow-up, the next talk is about follow-up care, the disease management programs, and use of a checklist. And this is a checklist You must have seen it already on an institute of Sandeep Seth, and patient will know whether he or she is in the red zone, yellow zone, or green zone. So heart failure is a team sport. It is not an individual sport. And heart failure nurse is a very important person, key person in the heart failure team. It is not a supporting actor, but a main actor. So now coming to nursing per se. This is first part was the general knowledge about pre-discharge things to be done. So the nurse should know who is going to be discharged, what are the medication to be given, and how are we going to implement the guidelines. So pre-discharge capabilities of the heart failure nurse includes recognition of the patients with heart failure. Sometimes they may be admitted for some time, something else, and maybe having heart failure. What were the triggers for the clinical deterioration? Importance of etiology should be identified, and the tools for diagnosis and monitoring should be familiar with. They should learn to assess and monitor the signs and symptoms. They should self-care and lifestyle advice to the patient. They should be able to give in confidence. The importance of pharmacological and device therapies has to emphasize but can re-emphasize. Importance of palliative end-of-life care. Importance of comorbidities. Understand the need of advanced strategies and demonstrate leadership in heart failure nursing. So this was the old pattern or even current pattern in many places. Patient gets hospitalized, gets stabilized, medicines are added, no additional education, no additional heart failure management. They go home and promptly come back. So this can be stopped, or this revolving chair, revolving door thing can be stopped by additional education, additional heart failure management by the nurse. And you should understand that for patient, there are multiple issues: pharmacological issues, non-pharmacological issues, including symptom awareness, self-management, who to contact. Other issues includes occupation, finances. All these things should be factored, including hobbies. That's important. Ongoing support, social, financial support. All these things are important when you plan discharge. Nurses play a pivotal role in pre-discharge planning for heart failure. How? By coordinating education, medication reconciliation, and follow-up care. So this is a pictograph. So what is the role of nurses? Patient education, discharge teaching, discharge planning, self-care behaviors, counseling patients, and identifying the clinical profile at discharge. So stressing each one of them, patient education is very important, including diet, fluid, daily weight monitoring, and medication adherence. They should have patient should tell back, or so that they have understood and reinforce self-care behaviors. Medication reconciliation is very important because they should make sure that medications are accurate, appropriate, and aligned with guideline-directed therapy. And all the dosing schedules and timings should be told to the patients. Coordination of follow-up care is very important. Risk stratification and tailored planning. So we should identify the higher risk patient, and it should be more aggressive, and they may get more advanced care that we send to a patient center with transplant facilities. That has to be done. Psychosocial assessment and support is very important. Documentation and communication is very, very important. If it is not documented, it did not happen. So they should document discharge instructions clearly and communicate them across the care team to avoid gaps or duplications. And what is the impact of this? This has been shown to reduce the 30-day readmission rates, improve patient satisfaction and self-management confidence, and lower healthcare costs by preventing avoidable complications. For this, what I said was a Western paper, but is it possible in India? And this is a paper published in August 2025, very recently, and this is by the nursing team, and you can see community health nursing person is the key person and the key author in this first author in this paper. And they had a nurse-led education program. So nurses are trained to understand heart failure, including the basic pathophysiology, common symptoms and prognosis, medication management, what is the purpose, dosage, side effects of heart failure medications, salt and fluid restrictions, daily weight monitoring. Also, symptom recognition and action plan and follow-up care. Simple things like what do you do when you have shortness of breath? That is taught to the patients. And look at the results. And very early results, 30-day readmission rates has been significantly reduced by this nursing intervention. And ladies and gentlemen, this is the key thing, because if the patient gets readmitted, the prognosis is bad. And the nurse has got multiple roles, but transition of care is our topic, but also about their psychological addictions, alcohol, social issues, all those things has to be under the gamut of the nurse practitioner, the chronic disease management program. Lastly, I come to the assessment, and this is very important, heart rate. Because you see here the difference between heart rate of 70 and 87. Or look at the jump when heart rate, this is pre-discharge heart rate. So if the patient is discharged with a heart rate of 90, their chance of cardiovascular death or heart failure hospitalization is much higher. You can see it jumps from nearly 15% to nearly 40%. So much of an increase. And so check the pulse. Pre-discharge pulse should be a quality indicator for nurses, and that has been done for 1 full minute. Blood pressure, again, many times blood pressure is taken very fast, so it should be resting. It should not be immediately after food or going to the toilet. They should be resting. Take multiple times and take the average of it. So this is a mnemonic which I developed with some help. So the heart failure pre-discharge checklist. So the All-India Institute checklist for the patients after discharge. So this is the mnemonic is discharge. D for diet and weight monitoring. I for instructions on medications. To review prescription dosages and timings. S is symptom recognition. C for clear follow-up plan. H for home support and safety. A for activity guidance, that is what is physical activity, and encourage gradual increase as tolerated. R is risk factor management, including alcohol, diabetes, hypertension, etc. G is goals of care, and E is education reinforcement. Like use teach back method. It's important. Tell them to say what they understood. Many times they look at you blindly. Spend time with them, and that will make all the difference. And the 5 A's, which I'm very fond of: awareness, accessibility, availability, affordability, and action. Each are needed, and this is relevant for the pre-discharge nursing care also. I conclude by this quote or the cartoon. So this is from allnurses.com. You mentioned that new nurses should not be afraid to ask questions. So that is what we all say. And feel free to ask questions. If not directly, or always, because put it in the chat box. We'll try to answer your questions. Thank you very much for patient hearing.
Thank you, Abraham, for that very nice presentation. Any comments or questions from that? Prabhakar, any comments? You are smiling.
No, sir. I think he gave a wonderful summary of the whole thing. I'm quite remarkable. In fact, I saw this, and in fact, I've taken my talk from the discharge, the mnemonic that we used. I think so. I think we'll have a continuum. Probably after we both finish, I think we'll have. There are some questions. You want to take it now, or you want to take it later? I can. But
I think you finish your this thing also. Then we will take the questions. Or towards the end, we will take. Yeah.
Right, Dr. Hari. So what I will be doing over the next 10 to 15 minutes is to give you a follow-up of what Dr. Abraham Oman has done. So Abraham Oman has been kind enough to tell you what to do, how to do, and how to discharge a patient, your discharge goals. So I think as a heart failure nurse, your role becomes very important, because manning the patient at heart failure by a nurse is very important. if you ask me why is this program so important for Heart Failure Association of India, is that we are trying to make a paradigm shift from the doctor-centric treatment, where the doctor just writes a prescription and sends the patient away, to educate the patients, get somebody involved in heart failure, educate them in heart failure, and then make sure that you are going to be the via media between the doctor and the patient. Patient is going to have more access to you and you are going to do the follow-up. That's the entire idea of the whole program, and that is what we are looking at. So what I will do now over the next about 10 to 15 minutes is to tell you how you're going to follow up your patient. Let's say you're a heart failure nurse sitting in a heart failure clinic, or you're the outpatient nurse in a heart failure clinic. So what should you first know about your patient? The first thing is the cartoon on the right side. I think you should understand you are supposed to become friends with your patients. That is the most important thing. Once you establish a rapport with your patient, that is when you're going to be forthcoming. The patient is going to trust you. You're going to get the things done. So that is how I'm going to talk about right now. So when you talk about any particular patient, you start by just knowing about the basic parameters of any patient. Heart failure nurse is supposed to talk to the patient by phone. He's supposed to take the phone calls, do a lot of things. I will talk about what all can be done by the nurse. So first thing, when you look at a patient's profile, you look at the age, the sex, because that will give you an idea of how healthy the patient is. Frailty, especially what it means is how frail the patient can be. An old lady or an old gentleman who can hardly walk. No point in trying to make him do a lot of exercise. I think whatever it's possible for him, you should do. And the educational background is very important, because you should talk to them in their terms, in their language. They should be able to understand what you're saying. Next, where does he stay? Urban, rural, house, or a flat, where you have a place to walk. A lot of patients live in areas where they don't have a place to walk. You walk right into the street, which is very busy. So you have to tailor your requirements to what the patient is and take down notes for each patient. That's very, very important. Look at the last point that I said. You will realize that taking down notes for each of these patients is very, very important. You also have to know the comorbidities of each patient, the diabetes, the hypertension, the other problems. Like if the patient might have a chronic osteoarthritis of both knees and not able to walk at all because of pain in the knees, and trying to make him walk every day, I think you're doing injustice to the patient. I think you'll have to be a little more considerate, start teaching them other exercise, do upper body exercises, start doing other things that have to be there. Special instructions for a patient, you have to take it from the discharge summary, which is what Abraham Moon was clearly saying. The fluid, the salt intake, the protein intake, the dietary instructions, they start at discharge. So ultimately, as a heart failure nurse, you are going to be running the heart failure show. So when you do that, all these points are very, very important for you to follow up a patient. So how are you going to follow up these patients is the next point we're going to talk about. Now, this is what Abraham Moon spoke about: discharge, diet and weight monitoring, instructions, symptom recognition, clear follow-up plan, home support, safety, activity, risk factor, goals, and education reinforcement. Now, this is the plan which is going to follow up on discharge. So I saw this and realized this is going to be the best way to follow up, and I will take each point as it goes. So the first one we're going to talk about is the diet and weight monitoring and the fluid restriction. So the diet, the most important thing the patient wants to know from you is salt restriction. Now, salt restriction has been spoken very variedly in different guidelines. It has been traditionally accepted in several guidelines, and you will see that salt is different from sodium. The sodium intake of 2 grams roughly translate to 5 grams of salt. But in principle, what is going to be the simple thing is avoidance of the excess salt that he takes. Restrict the salt 2 grams, or it is going to sodium of 2 grams, the 5 grams of salt is going to be very difficult, because that is going to be very difficult to explain to the patient. But primarily tell him, avoid the pickles, the urga, appalam, mixture, vatal that you say in Tamil. That is going to work. I think it works everywhere. Avoid those with excess salt where you're going to add salt. Most commonly, what I have done in my talk is I've added questions that patients are going to ask you if you talk to them on the phone. So which salt can I use is a very common question. There are several kinds of salt. The regular table salt is what people commonly use. Then you have the rock salt, which actually contains no iodine, but the sodium chloride is still very much there. Then there is an iodized salt, which we don't talk about much nowadays. Then there is a pink salt and the black salt. The pink salt is from the Himalayas, which is supposed to have trace elements, but technically it is nothing very great, because the amount of trace elements really doesn't matter. Black salt is the salt that you take in the chat that gives you that pungent taste because of the sulfur. So you just know about your salt, because you might come up with, the patient will come up with a googly and ask you, what is the salt? Which salt can I take? This, that, or something. I thought I'll add this so that you'll understand what is the kind of salt. Simple salt, all salts, you just try to restrict the total amount of salt in weight. Next is going to be the fluid restriction that is going to be important. Now, historically, heart failure has been associated with congestion, fluid overload, and a lot of studies have been there. And in fact, more recently, there has been a little more controversy, because we say that whether you restrict fluid or not, it seems to be, the outcome seems to be the same, and all kinds of stories have become. But the point is, you must understand, about 1.5 liters of fluid per day is more than sufficient for anybody. So when you talk about fluid restriction, it is important for you to first include all the fluids. It is not just the water intake. It could be the tea, the coffee, the soup. There could be the rasam that people drink here, and everything. All the fluids that you take are included. Commonly, 1.5 to 2 liters per day is supposed to be all right in most of the patients. And in patients with hyponatremia or advanced decompensation, your physician might ask you to take a lower amount of salt. So you have to follow that. Next, you also have to look at what about patients, whether he's stable or unstable. A lot of patients are very stable. They can tolerate most of fluids because they are able to do a lot of activity. They sweat a lot. You have to make allowance for summer and winter and make sure you're going to be there. Another important thing is diuretic optimization. See, diuretics are the drugs that remove the salt and the fluid from the body into the urine. Now, diuretics are given only when there is a fluid overload. If you're able to adjust the sodium intake and the fluid intake, you may not require diuretics, because diuretics are not prognostic. They're not going to improve the survival. They're going to improve only the congestion. So you have to be a little careful. And there's nothing like one size fits all to say. Depending on your patient, adjust it and do it. How to adjust it, I will tell you. Now, what is very, very important is the last picture here, the thirst. Now, thirst is a physiological way of the patient asking you and telling you that he's craving for water, which means that you're dehydrating the patient. What happens if you dehydrate the patient? The blood pressure comes down, you can't give the optimal medication, and the patient starts going in for a pre-renal failure, or the urea and creatinine starts going up. So thirst is something you must identify in your patient and start asking for all these patients. Next is going to be how to monitor these fluids. How are you going to measure it accurately? How are you going to do it? Or a fair estimate of fluid is going to be there, but weight management is the most sensitive indicator of fluid overload. So weigh the patient every morning before breakfast, after urination, because if you add a bladder full of 200 ml of fluid, urine, you're going to have a 200 milligram weight that is going to be high. Use the same scale, same time, similar clothing with 100 gram sensitivity. Record weight every day so that you know what to do. How to monitor the weight? That's what happens. More than about 750 grams per day, which is about 3/4 of a kg. So what you should do? Buy a weighing machine, which is about 100 milligrams sensitive. If you don't do that, you're going to miss out on this. So 0.75 kgs per day, or if a patient gains more than 2 kgs, it is a harbinger for an acute decompensation. If there is going to be a 3 kg weight gain per week, again, there is going to be a problem. Now, these are things that you educate the patient and ask the patient. How you ask, we'll come to later. But this is something about fluids. 0.75 kgs per day, 2 kgs in 48 hours, and 3 kgs per week. This is the guideline directed value. So we have seen about the diet, mainly the salt, the fluid intake, and how to monitor the fluid very simply by weight management. Next, instructions on medication is something that you should know. You have heard a lot of talks about the guideline-directed medical therapy, the 4 major therapies, and how everything is being done. But you must tell the patient during a follow-up about the purpose of each medication, which has been taken already, so I don't want to repeat that part, and how to take the medication and when. There are a lot of patients who come and tell you, I don't take it twice a day, but I take it only once a day. Now, there are a lot of medications like the Arni, the sacubitril valsartan, which don't act once a day. You have to take it twice a day. But there are some drugs like the epinephrine or the dapagliflozin or empagliflozin, which can be given once a day. So depending on the drug and the patient, you have to discuss the timing, the dosing, and what to do in missed prescription. Suppose I missed the morning dose, what can be done? Now, within 1 half-life, which is going to be, if the patient's on twice a day, you can take the drug in the afternoon also. 24 hours, even up to evening, you can still take the dose. But beyond that, you can't repeat the dose and take the dose the next day. So these are some simple things that patients will ask you, and you will have to be answering that. Monitoring and safety parameters are important. Managing side effects again are very important. And lifestyle integration, we have already said about that. Polypharmacy, medication. Patient also asks you a lot of questions about additional questions. Simple things. If I have a fever, can I take a paracetamol? It's safe. If you don't know, please ask your physician or your consultant and you know. So what are going to be the basic major symptoms that the patient is going to talk to you? Patient tells you that he's got a leg swelling. It just means very importantly that there is going to be a weight gain and there is going to be probably an adjustment of the diuretic dose. There are physicians who give an additional diuretic. So in that case, you ask them to take the diuretic. But I think it should always be under the supervision of your physician and your institution. Fluid intake becomes very important. If there is going to be a waterlogging, probably you restrict the fluid at that point from, let's say, 1.5 liters to 1 liter or 800 ml. The most second common thing that patient says, I'm extremely tired or fatigued. Now, what do you tell those patients? Those patients, it's important for you to understand. Look at the blood pressure, look at the pulse. We are targeting a pulse rate of 70, as Dr. Abraham had said, but hypotension is important. Systolic BP less than 90 doesn't matter really. But if there is symptomatic hypotension, patient is having symptoms, you probably have to consult the physician and start getting down. So not the blood pressure, it is symptomatic hypotension that is very, very important. Somebody says of cramps, you probably suspect electrolyte imbalance. Ask them to check the serum electrolytes. You might have a potassium that is low or the sodium that is low. That will help you. Burning sensation of the urine is something I'm sure the dapagliflozin and empagliflozin talks have told you. Now, if that is happening, probably there is a urinary infection, temporary withdrawal, and once you're treated, please encourage the patient to restart telling them it has a lot of benefit in the long term. That's where you come into the picture because your word is going to be important because you are the best friend to the patient. Genital infections are again known as DAPA or empagliflozin, temporary withdrawal, genital hygiene, and start looking at how best to improve the patient. Tell them to encourage them to wash their genitals immediately after passing urine each time. Low pulse rate again is a very important, interesting fact. Most of the times I've noticed that patients have ventricular bigemini or ventricular arrhythmias. So what happens when they put a pulse oximeter? It tells you the pulse rate is 50, their actual pulse rate is about 100 because the pulse oximeter picks up only half the rate. So you have to be very careful about how to follow up these patients. So far we have seen two parts. The next is teach the patient about warning signs. Now, what could be the warning signs or what could be the red flag triggers? We already said two things. Weight gain of 2 kgs in 2 days, 3 kgs in 1 week. The other very simple thing is worsening breathlessness, increasing swelling, abdominal swelling, especially the swelling and pain in the right hypochondrium, which is where the liver is and that starts to get congested. Patient says, my urination has come down considerably. And patient says, I'm not able to lie down at night. I get up in the middle of the night with breathlessness, that's orthopnea, or your chest pressure at night, which makes them cough or get up at night. And it takes about 30 to 45 minutes to become all right. These are red flag and warning signs that you have to be aware of. And you have to be telling your patient about that. So next, what you do is what about the follow-up? Now, generally following a discharge, Abraham Woman said about discharge, when to discharge. The first week following discharge, 1 week post-discharge is a very important time where you can readjust and tweak a medication. Encourage the patient to come back. He might say, I'm feeling all right, but that is when the dose increase and the dose adjustments become very important. So general follow-up is 1 week after discharge. Home support, I think this is what makes you develop a good rapport with your patient. Be empathetic towards your patient. Ask him, how is your family? Who takes care of you? Who looks after you? Ask him about who is there in the family. Now, this is when you become friends. Patient develops your trust. And once that happens, you are a very successful home nurse. You are a heart failure nurse. That is most important because when you do this, talk to them, know about their family, and please take down notes about each patient. You can't keep asking the same questions again and again. The doctor might do that because he hardly remembers. I do at least. I'm very poor at that. But as a nurse, when you start, patient correlates with you and you are the via media and you are the most important person there. Next is going to be activity guidance. Now, I'm not going to talk much about activity because there is going to be a separate talk on that, but just a few points. It is very, very important for these patients to be active. Severe heart failure does not mean take rest. It improves the overall efficiency. Patients actually improve. There is going to be a separate talk. I will just give you the gist of how to do it. Start slowly, go steadily, listen to your body, set a routine, and combine rest and movement. And what activities are going to be there is going to be there. Simple, again, same thing. Start slow, increase slowly. Light household activity, stretch, breathe, and use a talk test. Now, that is important. I hope my next speaker is going to talk about talk test is something that is meant for all cardiac patients. If you're able to talk while you walk, when you walk, you must be able to talk to the person walking next to you comfortably without breathing, being breathless, I think you're walking at the right pace. So you can go to a pace where you are able to talk while you walk. That is a talk test. And certain things are avoided. Avoid heavy weights, but about 5 to 7 kilos is easy. Skip high intensity exercise. Don't go for HIIT that people keep talking about in gyms. Avoid extremes of temperature. If you're going to be there, make sure that you're taking your medical advice properly and take rest. Don't push yourself beyond a particular activity. But this is important. What are the warning signs for patients during physical activity? One, if you have chest discomfort, pressure, or pain, if you become breathless, if you have extreme tiredness or lightheadedness, which could mean hypotension, rapid or irregular breathing, you feel there is a palpitation that's happening in you, significant weight changes that keep happening, don't try to do exercise. Get back to your doctor or your nurse. Get to know what's happening. The swelling increases, be cautious. Those are very important signs. Now, if you're sick for some other reason, let's say you cough out blood or you're vomiting or something else happens, these are important warning signs that you should be aware of before treating your patients. So you set realistic goals. We're going to talk about it later, so I will not push you too much into that. The next point about that is the risk factor management. I didn't talk much about it, basically because important thing is you talk about the risk factors once you know their comorbidities and emphasize the management of smoking, alcohol, and diabetes. But again, the goal of treatment is to make your patient live, control the heart failure, prevent hospitalization, and emphasize that he follows up, he's going to do well. Finally, education reinforcement is through a teach-back phenomenon. Abraham mentioned teach-back, but I thought I will stress what is the teach-back phenomenon. I thought the best way is not to give you all these things, to give you an example. Let's say you tell a patient, you take your blood pressure medication regularly. It's important to take it every day. That is telling the patient. Now you ask him the same question. Can you tell me how will you take your medication? Then he has to answer that I'll have to take it every day because you say that it is important. That is teach-back method. Now this is a general teach-back method. What about heart failure? Very simple. You tell him what is daily weight or ideal weight is. You tell him your weight is going to be, let's say, about 75 kilograms. Teach-back, you ask him what should be your weight. 75 kilograms should be my weight. I should be about it. Then you ask him what should be, how much of weight gain I should be cautious of. You tell him not more than 2 kilograms in 2 days and 3 kilograms in 7 days. You have succeeded. He has understood. He has told you back. That is teach-back method, which is what you should be advising. So in a heart failure follow-up, the key nursing summary is going to be salt, diet, we discussed, fluid management, tell the patient, but be cautious. But nowadays we are more relaxed about the patients, but because sometimes overdoing of the fluid actually falls the blood pressure. So be cautious about it. Daily weight management is important. Talk about activities is extremely important. The talk test is important. Warning signs I've already given you, and self-care. Finally, how do you talk to a patient? As a heart failure nurse, how can you practically talk and give your emphasis? How are you? Start with a phone call. You talk to them. How are you doing? You're doing fine. Great. That's wonderful. Next, what do? Are you taking your medicines regularly? Go to the right panel. Are you taking your medicines regularly? Yes, sir, I'm taking my. Are you taking this? No. So how many do you take in the morning? That's a talk back or a teach back. How many are you taking in the morning? You have the prescription. You know, he's going to take 3 drugs in the morning, 2 at night, and 1 in the afternoon. You know what is the teach back. So how's your diet looking? Are you managing salt? No, sir. I had Diwali. I had a lot of these sweets, all those things. So you come to them and tell them, no, it's dangerous. You might get into hospital. Fluid restriction, again, the same point. Weight management, they're supposed to maintain a chart. You tell them how to monitor the weight and check that and tell them, see, you're gaining weight. Be cautious. Be clear about it. Next, you come to how active are you? That is very, very important. Activity is important. Why is a separate talk? I'm sure the next speaker is going to talk to you about it. He's not at all active. Look at why the causes are. Is he frail? Not possible. Little active, encourage more activity because activity generally improves. Finally, stress on the warning signs. Chest pain, breathlessness, dizziness, leg swelling. That's going to be important. When you close shop, ask him, when are you supposed to meet your doctor? If there is going to be a problem, try to give them a follow-up. I think the final message that I have to give you is the heart failure nurse is the best friend for your patient. I think you should remember that. And with that, I will say thanks to Dr. Hari and Dr. Abraham Oman for giving me this excellent opportunity to interact with all the beautiful nurses who are here, who are going to be the future. I expect all of you to make a very big difference in the management of heart failure. Thank you so much.
Oh, Prabhakar, that is really wonderful way to put it. So many comments are coming like that. We will go to the comments and the questions later. I think we will have Dr. Abraham Babu's session, and then we will take the questions finally. Anyway, that is wonderful and very practical and very useful way of communicating with the patients. That is the most important. Now we'll go to Abraham for the physical activity part of it, which is also equally important. Recently, we presented a study in Heart Failure Society of America where it showed for the first time that physical activity improves the combined endpoint of mortality plus hospitalization. First time. So a study done from India. The first time in the world, but the study was done from multiple hospitals in India. So that makes an important, very, very cost-effective management to improve the mortality. So over to Abraham Babu for this talk on physical activity and exercise in heart failure.
Thank you, Hari sir and Abraham sir, for the invitation to be here, and I'm privileged to be here as part of the and present to you today as part of this course that's running. I think both Dr. Abraham and Dr. Prabhakar have laid the foundation beautifully. I think nothing beats your post-discharge care, and I'm just going to link a lot of what has been said and try bringing it in towards physical activity and exercise and heart failure. So this is some of my funding and disclosures. I think before we start, it's quite important for us to understand the basic concept between physical activity and exercise. Many times they are used synonymously, but there are conceptually different. So physical activity is defined as any bodily movement that's produced by skeletal muscles, and it results in some form of energy expenditure. A simple thing as gardening, stair climbing, or walking to a shop. Now, exercise is a subset of physical activity. The difference here is that this is planned, structured, and repetitive, and it is performed to sustain or improve health and fitness. So this is where a lot of your structured exercise programs, it may be at a center where you're using a treadmill or a cycle, but I'm not going to focus much on where you actually exercise. I'm going to talk to you about some simple algorithms that we have developed over the last 15 odd years that we've been doing a lot of heart failure rehab work. And a lot of focus is on simple strategies that we use to promote exercise and physical activity. So now that these two concepts are highlighted, I just want this to be clear to you that physical activity can be anything and exercise is always structured and planned. But this is also links in with cardiac rehabilitation. And cardiac rehabilitation is the bigger picture that we always talk about. And it is a multidisciplinary approach, especially for patients with heart disease. And it improves symptoms, functional capacity, metabolic status, depression, and health-related quality of life. These are now the current core components of cardiac rehab. And the importance, as you can see on exercise and physical activity, is significant. Of course, all of these work in the setting of guideline-directed medical therapies. These work the best, and the best outcomes are obtained when patients are on guideline-directed medical therapy. So the current core components do focus a lot on exercise, and that is why we talk a little bit about physical activity and exercise. There is enough evidence to say how beneficial exercise is, right from the cellular level up to various physiological systems. We have benefits, especially in heart failure, with respect to both exercise and physical activity participation. When we look at the subgroups of heart failure, both across reduced ejection fraction and preserved ejection fraction, we see improvements in clinical events. We see improvements in exercise capacity and obviously quality of life. And when it comes to, again, physical activity and specifically aerobic activities, we see a lot of changes again across various systems. So it is no surprise that exercise and physical activity works. The question is, how do we actually go about promoting physical activity and exercise? Now, the goal of any physical activity promotion program is to move someone who is completely sedentary towards a less sedentary and a more physically active status. So all you're trying to do is just move them slightly from one corner to the next corner. We're not expecting them to become marathon runners overnight, not at all, but we want them from sitting to at least getting up and moving in their home and gradually moving out of their home. And so on, progressing very gradually. The WHO recommends all of these. Now, these are numbers that we are all familiar with, but it's very important that we take into account our heart failure patients. Many of them are also aware of these numbers. And then a lot of times they actually feel quite disheartened that they are not able to meet these requirements. I think it's important that as a healthcare team, each of us speaks the same language. And I think Dr. Prabhakar really mentioned that it's important that they do how much they're able to do and gradually increase and not aim to reach the highest levels immediately. So I think even though these recommendations are there, we need to understand these are for normal, healthy individuals, not for the heart failure group. We need to dial this down by at least half or lesser than half, and then think about what is it that we want them to achieve. So I have a different strategy that we've used, and I'll talk a little bit about that as we move on. The European Society of Cardiology guidelines in 2021 on cardiovascular disease prevention actually have talked about how you look at just minimizing sedentary time. So from someone who sits a lot, all you do is simple things like just getting them to stand for a little while. It may be if they're watching a lot of TV, when the advertisements come, have them stand, walk a little bit, a few steps towards the TV and back, and then sit back down in their chair. Those are simple strategies that can be used to replace sedentary time with some form of physical activity. And any level of physical activity is considered better than none. And this is the dogma that we use for all of our patients with both heart failure and pulmonary hypertension. And what can be considered? What do we do for all of this? Obviously, all of this starts with a baseline assessment, because it's easy to think that we are doing something, but unless we assess it, we really do not know. There are both subjective and objective methods. The questionnaires are long, but there are also very simple questions. And one that we use commonly in our clinical practice and in our setting here is the physical activity vital sign. And it just has 2 questions, and I'll show you those a little later on in one of the other slides as well. We've also been using wearables. So we recently completed some work in cardiogenic shock survivors where we've used, which was funded by the Heart Failure Association of India. And we were able to actually use wearables to track some of their activity patterns from discharge all the way home up and at different intervals over a 6-month period. And these are simple, not very expensive tools that can be used. And all our patients have smartphones. Many of them do, or they have relatives who do. You can always think about syncing something with them and giving them a small device. This helps establish a baseline of activity that they do, and then we gradually look at increasing it from there. What do we want to advise our patients? To stay as active as they can. If using wearables, you can use step counts to promote physical activity. But remember, increase step counts by very, very small amounts. It is if someone does only about nearly 300 to 500 steps a day, that's all right for them. And all you get them to do is increase 100 steps more or 200 steps more in the next week. And they need to be comfortable, as Dr. Prabhakar said, they need to know their body. And it's very important that they learn to monitor their own symptoms. And I'll talk about another tool that we use besides the talk test as well, and talk about another one that we use very often. We also encourage participation in activities of daily living, and this is beyond just bathing, changing, and looking after themselves. It also involves some of the other things. So there are what we call as instrumental activities of daily living. And these are activities that involve some degree of interaction, calculations, managing some finances, or just getting involved with certain activities of running the house and being involved with some of their activities. Those are also quite important to keep them going. And think about short bouts of physical activity in a day. Like I said, if they're watching serials for a whole day, when the advertisements come, have them just stand, walk a few steps, come back, and then sit back in their chair. Or have alarms set that it beeps after every 1 hour, they stand up, just take a few steps around and come back. And that itself is a good way to build up your step count through the day. Now, what about exercise training? So now we know that physical activity is one component and exercise is another component. So when it comes down to exercise training, when do you start them? And this is going to be a lot of work that we have done over the last few years. And the recent work, Dr. Hari and Dr. Jimon from Chitra have also been involved with us. We've been starting this work right from the cardiac ICU itself. And this is work that we have been looking at the past few years, looking at acute heart failure patients. And it starts right from here all the way up to their hospitalization, to the wards, to discharge, and all the way to their OPD clinics. So this is the entire spectrum that we have. And our proposed pathway that we have to facilitate the continuum of heart failure care starts right from ICUs, which we initially start with just a little bit of early mobilization once they're medically stable. And then once they're in the wards and their subacute phases, continue to promote that activity with referrals. So you need to have early referrals to rehab right from the ICU onwards, with discharge evaluations coming in and then subsequent home-based programs being implemented. This is the recently developed mobilization algorithm that we have for acute heart failures. And we found this to be a very feasible option. And we're looking to scale this up and implement it on a larger scale. It looks quite complex, but we have training modules for this. And once we incorporate the training to therapists, they're actually able to very safely mobilize patients and de-escalate their progression just by excellent monitoring and clinical examination. So this is something that is immense potential to get patients moving right early on once they are stable, and then transition them to home-based care or rehab programs subsequently. This is a proposal that we had put forward years ago. It's based on the work that we do at our own center, where participants have the option to choose between an institution-based program or a home-based program. These days, we focus mainly on our home-based programs, and we don't have too many takers for our supervised institution-based programs, but quite simple, in fact. And discharge evaluations are always important. They can be easily incorporated into standard care pathways. A lot of our patients who are referred to us all have functional evaluations done at the time of discharge, which involve a 6-minute walk test. We also use the 1-minute sit to stand, which is easy enough to do. And it allows us to even follow up with patients at home, because we can have them perform this while they're at home. And over a video call, this is easily done. We also look at very structured physical activity and exercise prescriptions. As a medical practitioner would prescribe a medication, we are very clear about the intensity, the duration, and the amount and the volume of exercise that needs to be done. So it's important to prescribe the right exercise. Where can you exercise? Well, obviously at home or at the center. If you're doing it at the center, you have access to a lot of equipment that you have, but we all know this is challenging in our context, and it's very hard. In tier 1 cities, it is possible where people have sufficient buying capacity, but in many of the other centers and in other cities, we struggle a lot to achieve supervised cardiac rehab programs. This is work from our pulmonary hypertension patients, and this was pictures from manuals that we give our pulmonary hypertension patients. But these are simple exercises that we give even our heart failure patients. We ask them to do it at home. These start off very simple and then are gradually progressed with the addition of water bottles as weights. And of course, you can also use elastic bands, which we also are doing currently now for one of our other studies. These are just some examples to show you a patient with heart failure with pulmonary hypertension, actually, who was exercising at home. Now, she was privileged, like Dr. Prabhakar said, many people don't have the luxury of space, but she had a sufficient large space outside her home, so she could obviously walk. And of course, spot marching is another thing that we encourage them to do at home. And this is something that they can gradually progress, start slow and gradually progress, but they need to be safe. So when she started, she would initially hold the wall or the side of a windowsill and then start doing so with a chair. Sorry. So the home-based model works really well, and we've been doing that a lot. It starts with just simple phone calls, and like Dr. Prabhakar said, it involves having a relationship with your patient. You need to talk to them, you need to know them, you need to know what they do. We monitor a lot of our telephone calls. We have records, so it helps us progress our patients quite well. And we use different ways. It's of exercises at home. For those who are able, we obviously think about using video calls, text messages, emails, and it definitely helps patients of ours who stay far away. how hard should you exercise? And I think Dr. Prabhakar did touch a bit up on this, but we use the Boggs rating of perceived exertion scale, and we found this to be extremely helpful. It takes a little bit of time to teach our patients to use it, but once they use this, they apply this across all activities that they do. It has to be only between light and somewhat hard, and anything that exceeds that limit, it's an indicator for them to stop and tone down the exercise or the activity that they are doing. I just added this talk in after Dr. Prabhakar was talking about the talk test. So this is from an old slide, so sorry the formatting isn't right, but this is another tool that is being used, and it's the intensity of exercise that allows a person to talk comfortably without gasping for air. We've used this in some of our pulmonary patients as well, and obviously we did it for a while, but we primarily use the rating of perceived exertion, but this is simple enough to use in a clinic. It's very important to ensure regular follow-up and monitoring of exercise and symptoms. And if they have high levels of exertions, this is a red flag. And as nurses who will be following up, I think it's important that these should be in a red flag. And I think the reasons for it, Dr. Prabhakar has already highlighted. We need to be watchful for any sudden changes in their levels of exertion. We focus a lot on educating them on when to stop their activity, and Dr. Prabhakar has mentioned a whole lot of symptoms, and I've just added a few of these that are there, and these are again quite important. So we think about worsening breathlessness, chest pain, leg cramps, sweating, lightheadedness, pale appearance, and palpitations. It's very important, and it's also important that you tell your patients that the amount that they do one day may not be the same that they do the next day. So they have to really understand their body and really know how it responds, and they can tailor it. It doesn't matter if they do lesser exercises one day, it is perfectly fine. These are our modules that we are using as part of our ongoing research now. So these are small exercise plans that we have given our patients. They monitor them at home. We follow up with them at frequent intervals. Simple images just to guide them with respect to what they should look for: swelling, weight gain, chest pain, breathlessness. And of course, it also includes adherence to medications and their fluid diet managements as well. So these are simple things that can be used and given as placards or cards to your patients and followed up with them every week. So what can we do to promote all of this? We know these all sound wonderful, they're all excellent, but what can we be doing? Well, it starts with improving awareness, both for patients and among the healthcare professionals, that exercising in heart failure is possible and is not something that should not be done. Rather, it should be something that's done. And we've done some, I think Sri Chitra, Dr. Hari has done some wonderful work with patient groups. And I think this is something that needs to definitely continue on a much larger scale. There has to be better training. So especially in the broad sphere of cardiac rehab, as the vice chair of ICCPR, we do offer a cardiac rehab certification program online. And that's one way to train people. This course that you're attending is one way to do it. Task sharing and task shifting are some options. And I think there was a comment related to this. And one of the things that can easily be done is sharing the load. So if there are tasks that can be managed by another healthcare provider, it does help actually in managing some of this. And also think about affordable clinics by piggybacking on existing health systems. Many often, it is easier to piggyback on a clinic that's running well and have one small stream that starts off looking at those with cardiac disease and heart failure. It's important to facilitate referrals. At our center, we have a lot of blanket referrals. So patients come in, we do take them, but you can also think about automated referrals, or you need dedicated staff who are there to identify eligible participants and then think about promoting them. This is an online course that's available that is free online that offers training to promote patient participation in cardiac rehab. And I think all of you in the audience can access this and do it. It's a wonderful resource to look at. Create heart failure rehab teams, and this is along with the overall team. So this is going to focus purely on rehab, and it has to focus on different groups working together, and all of them need to work in collaboration with the cardiologist or the heart failure specialist. And that's definitely a way to go in looking at collaborative care. Focus on served populations. And this is work that we have done in women. This was in coronary artery disease, but I think women with heart failure are greatly understudied. And this was work done by one of our nurses for her PhD here, and we've just published this earlier this year in European Journal of Preventive Cardiology. So technology is something that can be used to promote rehab and improves functional capacity, quality of life, and health behavior. And it's time we transition this and pilot it in the heart failure model as well. We need to think about advocacy, and I think the HFAI and the Nursing Council will be ideal people to do this. With respect to the vital sign, we think about including physical activity as a vital sign so that it gets recorded, it gets managed. It's a good indicator to monitor progress. This is done by the Kaiser Permanente. They've been doing it for years in the United States. 2 questions. How many days a week do you perform some form of activity? On average, how many total minutes? The number of days into the number of minutes gives you the minutes per week of activity that is done. It's as simple as that. And it can easily be recorded as part of your regular assessment sheets. And it gives you a good way to collate a large volume of data in a very simple way. Capitalize on the acute phase. We do that a lot. Recovery is a time where it's a very teachable moment. So facilitate through patient education, various components that you want to facilitate them to resume their activities, adhere to medication, symptom management, follow-up care, very important. And we have shown in one of our work earlier that it's important to engage healthcare providers, especially nurses, to promote cardiac rehab and for patients to participate in them through your regular face-to-face encounters with them. So this is something which definitely should be done, and you'll see this coming out in the new roadmap by the World Heart Federation as well. Make use of technology, and we've talked about that, from the simple phone call to a video call. Do not underestimate the value of a phone call to a patient. So to conclude, what I would like to say is that participating in physical activity and exercise improves various physiological processes. It is an evidence-based recommendation for heart failure. These evaluations can be easily incorporated into clinical practice. They're not laborious. Referrals to rehab with support and encouragement from nurses will facilitate greater uptake to physical activity and exercise in heart failure. This is some information on a cardiac rehab foundation course being offered by the ICCPR. And if any of you are interested, you can view this at a later point. Thank you for your attention.
Thank you, Dr. Abraham Babu, for that wonderful presentation. I think the cardiac rehabilitation is not given much importance as is due to it, because we know that people will think that what is there in just getting up from his chair and do 3-4 times, how does it help in heart failure? But that makes a lot of difference. It improves the confidence of the patient. It improves their outlook to the disease, and it makes a lot of difference. It improves the anxiety and depression. They become more confident, and becoming more confident means they will adherence to the therapy will be much more improved. So I think it is very, very important to have very simple exercises. We need not have a very elaborate setup. Everybody will think that you need a treadmill or you need gym-like equipment. Nothing is needed. Just a simple room with a chair, and if you have a stepper or something, that is the only thing which is required. So I think everybody in this group should try to start with your physicians or cardiologist, who are you working with to initiate such programs. So I will just present on the heart failure clinics, and then we will have the discussion at the end. Then so many questions are there regarding when will be the post test. The post test will be after the last talk. You will be sent a link. You can click on the link and start answering the questions. There will be 25 questions. You have to answer 20 questions correctly to get the certificate. So you can take any number of attempts. So the number of attempts will not be reflected in the certificate. These questions are not very easy, I admit. You can take it once more, and you will be getting the required percentage. It is basically to drive some messages on heart failure rather than testing the knowledge. It is basically to improve the guideline-directed medical therapy in heart failure. So I will just start sharing my presentation, and Hope you can see my slides
Yes, sir. It's not on screen show, though. That's all.
now.
Yes, sir. All good.
Yeah. So my talk is on need for heart failure clinics in India. So that is this is the reason why it is important because we'll start with some basic data and then this is basically a recap of the whole sessions, and then we will go to the heart failure clinic proper. So this is the data from our Indian registries. You have heart failure with reduced ejection fraction, that is less than 40%, is 2/3. You can see all are 66, 67. 2/3 of the patients in India are heart failure with reduced ejection fraction. And preserved ejection fraction, that is more than 50%, is only 12 to 16%. That's a very smaller percentage, less than 1/5. So that is the first thing. Probably we may be missing some of the preserved ejection fraction patients. That is a different question. And among the etiology, it is ischemic heart disease, 3/4. Nearly all the Indian registers have shown it is more than 70%. It's followed by dilated cardiomyopathy in around 17%, and rheumatic heart disease, valvular heart diseases contribute to around 6 to 7%. So these three diseases, ischemic or coronary artery disease, dilated cardiomyopathy, and valvular heart disease, mostly rheumatic heart disease, contribute to around 95% of the burden of heart failure in India. So we have to concentrate on these three diseases. The mortality is very high. The Indian registry, so the in-hospital mortality is 7 to 8.5%, which is higher than 4 to 5% in the high-income countries. The long-term mortality is also very pathetic. 1 year mortality is 30%. The recent National Heart Failure Registry data shows it is around 22%. This long-term outcome is from the Trivandrum Heart Failure Registry, where we are following the patients for more than 10 years now. So 3-year mortality is 45%, 5-year it is around 60%, and 10-year the mortality is 83%. So it is higher than many common cancers like breast or colon. So that is the importance of that. If you give guideline-directed medical therapy, we can improve the outcome of these patients. So what is how well are we treating these patients? That is the next question. We are not treating them well because only 25 to 47% of the patients receive guideline-directed therapy. The guideline-directed medical therapy in the National Heart Failure Registry is good because it was done in the teaching hospitals. But many other hospitals, we recently are doing a program where the even one drug of the 4 pillars are not prescribed to patients. So that is reality which is happening in the community. So next is why we need heart failure clinics. So we know that there is a paradigm shift in the heart failure management in the last 2 decades. We know that in the 1980s or 90s, when we were doing our training in MBBS and MD, there were only very few drugs which was available, only diuretics, digoxin. These were the drugs which was available. Now we have an array of therapies like disease-modifying agents. We have the 4 pillars of therapy for heart failure with reduced ejection fraction. We have devices like CRT or ICD to prevent a sudden cardiac death, and also rehab, management of depression, anxiety. All those things are there in the. So it is a comprehensive care which is being provided. So this is the specific treatment of comorbidities like chronic kidney disease, LVAD, and advanced therapies, iron deficiency correction, valvular heart disease management, sleep apnea, management of atrial fibrillation, then vaccinations. All these come under the comprehensive management of heart failure. So that is where this is not very simple, where you treat like coronary artery disease. It's a very complex thing. That is why you need a specific setup called heart failure clinic, where you can streamline the therapy. This will require the collaboration of multiple specialties. You may need to refer the patient to a nephrologist, physiatrist. Then you have to refer to a psychologist for depression. All those things are there. So this is a comprehensive care we have to provide, which can be provided in the heart failure clinic. So the guideline-directed therapy, we have to consider 3 aspects basically. The first of all, we know that there are 4 pillars. We have to give all the 4 pillars. What are the 4 pillars? You all know. ACE inhibitor or ARB or ARNI. ARNI is the preferred among the 3. Then beta blockers, Then mineralocorticoid receptor antagonists like spironolactone, replerenone, or finerenone that we will discuss subsequently, and SGLT2 inhibitors like dapagliflozin, dapagliflozin. So next is we should give at the correct doses. That is a target doses or the maximum tolerated doses. For example, beta blocker, metoprolol, if you are giving the sustained release, that is the one which is recommended. So you have to go to 200 milligram OD. That is the target dose. But many patients, may not be able to go to that level because of low blood pressure and heart rate. So, for example, one patient, we have tried the maximum. We can go up to only 100 milligram. So that is what is called the maximum tolerated dose. So either the target dose, if it is not possible, you should go to the maximum tolerated doses. And the third thing is time to initiation and optimization of dosing. Usually we start the drug. For example, we have started Arni at 50 milligram BD. 1 month later, we call and increase to 100 milligram and 50 milligram. Then after 2 months, we called up to increase it higher and higher. So, so that is usually it is very slow. But we now have data which is showing that you have to titrate the drugs very fast within 6 weeks to 3 months. We have to go to the maximum tolerated doses within 6 weeks to 3 months. So are we doing that? We don't have any Indian data, but there's a CHAM heart failure registry which shows that at baseline, you can see number of percentage of people reaching the target doses. ACE inhibitor or ARB only in 11%, beta blocker only in 20%, mineralocorticoid only in 25%. But at 12 months, we think that we may do it on follow-up, but actually it is worse. ACE inhibitor ARB, it has come down. Beta blocker, it is slightly improved. Mineralocorticoid, it is slightly improved. So maximum 27% is only reaching the target doses. That is very, very important. So we are not treating these patients properly. So the next question is whether we should go to the target doses. This is a chart. I'm not going to the details, but shows that even if you reach 50% of the target doses, that is a maximum tolerated dose, you will get almost the same benefit. For example, Arni, you are not able to go to 200 milligram BD, which is the target dose. You are able to achieve 100 milligram BD. Then that itself will give almost the same benefit as you give the target dose. So this is the trial which I was talking about, that you uptitrate the drugs very fast within 6 weeks. You go to the target doses of all the drugs within 6 weeks, you will get the maximum benefit. So that is come in the European Society of Cardiology guidelines also. So why we are not doing all these things? We are not giving the drugs. Why we are not titrating to the target doses, and we are very slow? Because the major reasons for non-use are patients may be older age, patients are frail, patients have an injection, renal function is worsening, then older age, hyperkalemia, lower blood pressure, lower heart rate. All this may be reasons. What are the challenges in the Indian settings? Awareness and motivation among patients is low, lack of patient education, physician inertia. That is very, very important. Need for multidisciplinary care, as I have discussed initially. Lack of coordinated care and lack of crosstalk between specialties, for example, nephrology and cardiology, physical medicine and cardiology, dietary department and cardiology. This crosstalk is not existing or very minimal. Economic issues. For example, we ask the patient to come after 1 week. They may not have the money to come with the blood test. They should arrange somebody to come with them. Cost of medicines is a problem. Then the heart failure nurse concept is not there in India, and nurses do not have prescription rights as in UK or US. Then the lack of heart failure rehab facilities. Abraham is running a very good rehab facility, but such a facility is not there in many of the hospitals. So dietitians are not available in many of the hospitals. Counselors are not available, right? Who are accessible to heart failure patients. So the treatment gap, there's a significant treatment gap. I am not going to those details of this slide, but there is a significant treatment. So clinical inertia is the multifactorial problem. It is contributed by healthcare providers, that is the doctors and the nurses, patients and the healthcare system, And failure of the physicians or the cardiologists to see the importance of reaching the target doses remains a barrier. And that is one of the most important barriers we are trying to overcome by doing training programs for the physicians and cardiologists. Self-care behavior, like exercise, weight monitoring, dietary monitoring, control of sodium, all these are very low in the Indian system. So heart failure clinic can improve on this. So what is a heart failure clinic? It is an organized setup for the regular and systematic follow-up and management of patients with heart failure. It is aimed at improving their outcomes and quality of life. So it is a simple, organized setup for the regular and systematic follow-up and management of heart failure clinics. The goal is to reduce morbidity and mortality, to reduce readmissions, to identify contributors to heart failure progression, and maintain quality of life and quality of care. How this we are going to achieve this through heart failure clinics? By educating the patients, guiding the patients towards the best possible medical care, and providing a helping hand when they decompensate. We will discuss that subsequently. So, what are we doing in the heart failure clinic? The objectives are to ensure guideline-directed therapy. That is the most important, because guideline-directed therapy has shown if you give all the 4 drugs to a patient, 55-year-old man with heart failure with reduced ejection fraction, you will gain 5.5 to 7.5 years of life. That is important. No such therapy has been shown to produce such benefit so far in medical therapy. So 5.5 to around average around 6 to 7 years of life will be gained in a patient with heart failure with reduced ejection fraction if you give all the 4 drugs. And for protocol-based workup of these patients leading to accurate diagnosis. For example, if you have a protocol, you may not miss something. For example, patient is having amyloid, patient is having sarcoid. So if you follow a pattern, so in our clinic, when a patient comes to our clinic, we have a checklist. We tick where we have missed hypothyroidism or we have missed sarcoid. So there is a checklist for all the students. If you go through that, we may not miss a diagnosis and we may able to treat it much earlier. So timely referral for advanced heart failure care for transplant. For every time the surgeons complains that we refer the patients very late. By that time, the patient's condition is very bad. So early referral for high therapies, like high-end therapies like transplant is very important. Identify those patients who are likely to worsen and prevent a readmission, because readmission indicates a high risk group. Programming devices like CRT, helpline to patients in case of an emergency, and some data collection and research will always be a component. So how the heart failure clinic shown to benefit patients? Yes, the randomized controlled trial, 16 of them, and the meta-analysis showed that it benefits the patients. And this is a recent study which showed that utilization of GDMT increased from 35 to 85% when they were directed through a heart failure clinic. Ejection fraction improved, 6-minute walk distance also improved. So it benefits. So cost effectiveness, nurse-led heart failure clinics and telemonitoring programs are found to be cost effective. And who are the patients to be seen in the heart failure clinic? All patients, I will say all the patients should be seen in heart failure, especially those who are recently diagnosed and discharged after hospitalization. Readmitted patients, they should definitely be seen in a heart failure clinic. Other organ dysfunction, for example, they have lung disease or chronic kidney disease, those with low blood pressure, those who are requiring readmissions and frequent IV inotropic support, these patients should be seen in the heart failure clinics. So what are the components? What is the infrastructure? What is the personnel, equipment, processes, and database? These are all the things. Who should primarily manage the heart failure clinic? What I will say that it is the heart failure nurse, because physicians and cardiologists are busy. They will not have the time to closely follow up the patient. So a heart failure nurse is the most important person. So the non-inferiority of a heart failure nurse titration versus heart failure cardiologist titration of the drug, this shows that the nurse titration was actually better. So that is the importance. The nurse-led heart failure clinics showed improvement, and also the pharmacists. Some of the hospitals have a pharmacist-led heart failure clinics. So who should manage in the heart failure clinic in the Indian settings? It is the nurse practitioner. It is a heart failure nurse, trained heart failure nurse, who is the most suited in the Indian settings. Expertise required: heart failure nurse, cardiologist, or physician. device programming and for this already is all these things are there in your hospital. You can see that surgical team is always available, physiotherapy is available, dietitian is available, and psychiatrist and physiatrist need to be available on a referral basis. So the key person is the heart failure nurse who is properly trained. So training, we know that why training is required, because 2015 we have only ACE inhibitor and beta blocker and aldosterone blocker like spironolactone. 2020 we have ARNI and SGLT2. We have every time newer and newer drugs and therapies have been added. So we need to train and retrain the person, especially the heart failure nurse. So we'll have a training, retraining program at least every year for these patients, for this heart failure nurse. So what are equipments which we need? Nothing. Whatever you have now, you can start a heart failure clinic tomorrow when you go back and discuss with your physician or the cardiologist who you are working with. You can start a clinic, convert one day of your OPD to a heart failure clinic. You don't need anything new. Weighing machine is already there. Echo machine is already there. A point of care BNP device or BNP will be doing routinely BNP or ND-Pro BNP. ECG is available. VPPR is available. Pulse oximeter is available because you should get the heart rate also. Defibrillator is available. Device programming, many of the hospitals may have, those who are doing this, CRT and IC. And a hand dynamometer is a simple equipment which is available from Amazon for 5,000 rupees. That is to check the hand strength and assess frailty. Rehabilitation counseling facility should be available. As we already, Abraham has gone in details, I am not going to that. And counseling facilities and one-to-one counseling is very important. That is what Dr. Prabhakar was discussing. You should be a friend to the patient. Patient should be, sometimes they may not be willing to discuss about sexual dysfunction, for example. But if you have built a rapport with the patient, they will open up and they will discuss with you. Post-VAD or transplant care, these are specialized care which require supervision and training. What are the systems and processes? So you should have an evaluation protocol. When a new patient comes, how to evaluate the patients. So this will help in diagnosis and workup of ambiguous cases. And as already said, towards advanced heart failure therapies to a referral. Functional assessment, this is very important. NYHA class, 1 to 4 is the simplest way. 6-minute walk distance. Every heart failure clinic should find a way to do a 6-minute walk distance to identify a corridor in your hospital and allow the patient and make a protocol and make a questionnaire. We can also share, which we routinely do in all heart failure patients to assess the functional capacity. If they're less than 300 meters, they have a poor functional capacity. Then hand grip strength for dynamometer, I have already said. Biomarkers and some scores like MAGIC score can also be used. Quality of life assessment is very important. We have developed an Indian quality of life tool which is freely available. You can use that. It's very important. You can see how the quality of life improves for these patients. Checklist, very, very simple and cost-effective thing. You make a checklist for your ICU, for your OPD. Very, very important. You mark those when the patient comes. Have you sent the electrolytes? What was the what is the dose of the Lasix the patient was given? All those things will be documented and you will not miss anything. Checklist can be a discharge or the heart failure clinic follow-up. It's a cost-effective method. It is found to reduce the readmissions, and a nurse-based checklist is better. That is what is shown. So this is a 27 question checklist and discharge is one of the examples. So when should you do the first review? That is very, very important. The review should be, as already Dr. Prabhakar has mentioned, 7 days. That is the best way, best time to evaluate, because the first 2 weeks is the time when they develop this change in the hemodynamics. We have started on drugs. They have sometimes renal dysfunction. They may not, the fluid retention may be there. So this is the time when we review the patient and adjust the drugs. So 7-day review is very important. Either you can come to this hospital or you can refer to a local hospital. Dietary advice, low salt intake when the patient is congested. Not in a patient who is walking around having improved heart failure for many, many years. It is not, the low salt intake is not for that patient. Patient who have a features of congestion or patient is admitted, those patients will require a low salt intake. And for fluid intake is also similar. restricted fluid intake. Alcohol and smoking cessation, very important. These things should be, and malnutrition should be prevented. Patient may not be having appetite, so you should give a healthy diet, and excessive salt intake, more than 5 grams per day, should be avoided. Physical activity is already discussed. It is class 1 indication. And you can see the class 2A indication, those who are with more severe disease, very important. More severe disease, it is a class 2A indication to start the therapy. Some problem with this slide. Okay. Physical activity is very already discussed. I am not going to those details. Abraham discussed in the counseling is very important. Patient education is very, very important. And the posters, booklets, cartoons, you can develop your own. This is what we have pasted in front of our heart failure clinic. So you can have such type of posters in your own local language and use it so that it will help the patient. Patient will be sitting there in the OPD waiting. They will read this definitely, and it will help. And this is there's an you can make an app. This is developed by our own computer department, which is a smart app for the patients. Database, this is very important. What you can do is you can make an Excel sheet. Excel is available in all the hospitals, or if you have a hospital information system, you can use that. All the details can be entered. And in the clinic, you should have the phone number of the patients, 1 or 2 phone numbers you should collect and call the patients in between when they need. Follow-up care, it is critical to sustain the heart failure clinic. The first visit should be in 1 to 2 weeks. Then every 2 to 3 weeks, till 3 months, till drug optimization is done. When the patient goes to the target or the maximum tolerated doses, then every 3 to 6 months. You should give them a helpline number. In the office time, you can give the heart failure clinic number. You can your ICU number you can give for 24/7 support. So this I need help is the algorithm. You can, I already, Dr. Sandeep must have discussed with you. I'm not going to those details. Vaccination is also very important. 2 vaccinations. One is influenza and the other one is pneumococcal. These things are important in heart failure patients. So how is heart failure clinic relevant in Indian settings? We know that it needs multidisciplinary care, input from multiple specialists like cardiologists, cardiac surgeons, physiatrists, nephrologists, all are required. To have an established system of care all under one roof, it makes it easily accessible to patients. So if you have a system, this patient should be referred to dietitian on a particular, you can arrange the consultation on the same day as the heart failure clinic. For example, dietitian will see the patient, physiatrist or physical medicine specialist will see the patient that day itself. So if this reduces the waiting time, improves the interdisciplinary interaction, and adds benefit in the patients. And periodic quality assessment of the heart failure clinic is also important. Periodic retraining I have already emphasized. And this is from Greece to develop a national heart failure clinic network. There are some certain drawbacks also because palliative care patients are not usually cared for. Multimorbidity, generalization and simplification is not always possible because CKD and heart failure, they can require some specialist care. And home visit-based clinics are not common in Asia and Indian setting. These are all trained personnel needed. And coordination with the different departments is tough, but it can be done. And this is from University from Canada. They have renamed it as Heart Function Clinic because heart failure has a negative meaning. So they have started naming as Heart Function Clinic. So we also, when you start tomorrow your heart failure clinic, you can change the name as Heart Function Clinic. So to conclude, ladies and gentlemen, heart failure needs multidisciplinary care. Heart function clinics will bring comprehensive care under a single entity. It is shown to reduce hospitalizations and improve patient satisfaction. It will not need big infrastructure and require only few trained personnel. The nurse, heart failure nurse who is trained well is the key person. Is much relevant in Indian settings with the overloaded public healthcare system and a huge disease burden. There are challenges, but many of them can easily be overcome. So thank you. I think we will have the questions and comments now. Dr. Prabhakar.
Sir, Hari sir, I think I should congratulate you on summarizing the whole program in one 20-minute talk. I think all the talks, all the guideline directed and the vaccinations, the nurse, everything. I think you have summarized. I think that is going to be a grand finale summary that you're given. I think I should. That is very comprehensive and exhaustive and fantastic, sir.
And all the answers to the post test are contained in that. If you have listened, you will be able to answer.
Let's look at the results. That we'll know what happens exactly.
Yeah, I think we can have some answers to the questions which is posted in the chat box. So can we have those?
The first question is, how can I attend the post test? I think that's not going to work. When will we be able to post test? Post test has got more questions.
Yeah, post test will be done after this. We will share the link. It will not be in the Zoom. You will receive a link in your email or the WhatsApp. So you can start attending those. Open that link and start answering the questions. There will be 25 questions, and you can answer that. Start answering. When you get 20 questions correct, you will get you will be sent the certificate by email. So
you go ahead, sir. You finish. I'm sorry.
If you are not able to answer 20, the initial thing, you can attempt it again. Next time, I am 100% sure that you will be able to answer. The questions are all I have answered in my talk, most of them. So it is there. So I think it is it is not very theoretical. It is all practical questions based on real patient scenarios and all. You will just think about it and answer. And you have a chance of, and the number of attempts and all will not be recorded in the certificate. If you get 80%, I am sure you will get, and the certificate will be sent to you. Okay, so any other questions? So when will you do electrolytes?
There are questions in the Q&A.
There is one, sir, which asks about you. It says that nurses are working in nurse-led clinics in cardiology. They are working multiple tasks. Please share your opinions regarding this initiative.
Yeah, I think the heart failure clinic itself is a multidisciplinary task because you have to play multiple roles. You have to play the role of first of all a nurse, then you have to play the role of the counselor, you have to play the role of a friend, you have to play the whatever. No, it is you are what is it? The most important person. Once you start calling them and follow up, you will see the difference. You will see the difference. They will trust you, and the patient will feel confident. And don't think that they will call you in the night and disturb. They will not. You will given a helpline number. They will call in that helpline number. You tell that what our office time is this clinic number, and you don't give the personal number. You give the clinic number. If you have landline, you give that and give the ICU number. They will call there. So, and try to follow up. They are not coming. You have a list. You probably will have 200 patients. If you have 20 patients is coming today, but the 2 of them could not turn up. Just phone them and only 2 calls. Phone them and find out why they have not come. So, some unfortunate thing must have happened, or they have some issues not come. Then ask them to come next week and ensure that the guideline directed therapy is taken by them. That is also very important.
So I think that's a very comprehensive answer you're given, basically stating that the link between the patient and the institution and the heart failure treatment is the nurse. I think which the heart failure nurse should understand. I think you made a very clear point that the heart failure nurse is the important person who is going to drive the whole program around. I think which is the idea of the entire heart failure nurses program. I think that's beautifully said, sir. Next question also, I'll palm it off to you. How often electrolytes should be checked? I think it's very individualized. Your thoughts, sir.
Yeah. So electrolytes, whenever you are titrating the drugs, especially uptake, the patient who is, I will give you 2 examples. A patient who is stable, coming regularly for the last probably a year, stable, the drugs have been uptitrated to the full and absolutely stable. There's no need to monitor anything. But a patient who was recently discharged and we are going to uptitrate the drugs, then you better do an electrolyte and see before doubling the therapy, especially ARNI or ACE or ARB or spironolactone. In that case, it will be safer and you feel more comfortable, and the patient also will be more comfortable in doing that. Yeah. Any
Yeah,
other
so
point?
if I get what you said very simply, so it is primarily the physician, whenever he changes a drug within about a week or two, he checks to make sure that he tolerates the drug.
Exactly.
Can I make it simple? I think that should be the answer. I
That's
think
it.
next question is for Dr. Abraham Babu. I think you don't have to type the answer. You can answer the question straight away. While climbing stairs, patient used to say that they have pricking pain in the left side. What type of physical activity required for them? You can answer that, Dr. Babu.
All right. I had started just trying to put an answer
Yeah, I know. I
together.
saw you typing the answer.
So I think it's very. This is something that needs a little bit of thought. If the patient hasn't been evaluated sufficiently, I think it's good to have a discussion with your cardiologist just to make sure your coronaries are fine. That's probably one thing to start with. But if all is well, then remember that stair climbing is quite a high intensity activity. It is much higher an activity than level ground, and stair climbing is always a progression for us. But if stair climbing is inevitable, then one of the ways that we do pace it out and do is to maybe have the person climb a couple of stairs and wait for a little while, then again climb a couple of stairs, then wait a little while, climb a couple of stairs, and so on. And we minimize the number of times they need to go up and down. So if they are in a home where they need to go up and down, we minimize the time. So it's come down once in the morning, stay down, go back up once at night. That's it. So those are things that can be done.
So I probably add up one point. If you tell me if I'm wrong, probably do it on empty stomach and don't do it very fast.
Yeah, no, don't do it very fast. The empty stomach, yeah. I mean, we haven't. We usually don't tell them too much about that, but definitely not do it too fast.
Yeah, what I tell them is don't do it after within half an hour of food.
Yeah.
That is what I tell them. So you
Yeah.
can rest within 30 minutes of having food. Then probably you can immediately after food. No, there will be a much more hemodynamic requirement. So better to avoid after 30 or 45 minutes after a heavy meal intake. Yes.
I'll remove this question. There's a question on CRISPR gene editing. Now, there is a genetic basis for every disease, but CRISPR gene editing at this point of time is not very high on the priority list of heart failure. Let's just skip that question. What is the leading cause of rheumatic heart disease? Like, how do you prevent it? I think Dr. Harikrishnan is the right person to talk about rheumatic heart disease.
Yeah, rheumatic heart disease is the third commonest reason for heart failure in India. Around 6 to 8% of the whole registry data shows heart failure. 6 to 8% of heart failure is due to rheumatic heart disease. The most important thing is now it is significantly coming down because the living conditions in India have significantly improved. Previously, we used to do around 220 balloon mitrals. Now we are hardly doing around 60 to 70 because the mitral stenosis has significantly come down. Dr. Jayadeva Hospital, where they were doing 1,800, now they are doing around 600, I think. So significant improvement in the living conditions. That is the first thing, the primordial prevention, you can say. Then secondary prevention. That is the most important thing. Once you have developed the disease, rheumatic heart disease, then you have to concentrate on secondary prevention. That is by giving the penicillin prophylaxis. The best way to give injection benzanthin penicillin once in 3 weeks. If it is not possible, ensure that they take the oral penicillin, whatever form is available, 250 or 400, whatever the preparation is available. You should take it regularly. And the compliance is very low because it is mostly children and they may have to go to school, they may not take it. So ensure that and once the patient has developed the disease, then you have to closely monitor and intervene at whatever point. Sometimes they may be presenting at pregnancy. So you have to intervene and do for example, balloon mitral valvotomy or something at pregnancy. So that at all need to be done. So that is the answer for that. Basically, improving the living conditions and secondary prophylaxis if they have developed the disease.
So there is a question on cold weather affecting congestion. I think we'll not take much of it. I think Dr. Harikrishnan clearly said prevention of any respiratory infection with the annual flu vaccine, which used to be quadrivalent, has now become trivalent. And once in a lifetime, probably Prevnar 20 vaccine are guideline directed, mandatory. And I think the nurse plays a very good role in doing that. Apart from that, one important thing about cold weather is going to be that in hot weather, probably the diuretic dosage has to be scaled down because of the sweating, and cold weather, probably the fluid restriction, probably have to adjust that. Anything else, I don't think has to be added to that. I think I'll talk about nurse-led heart failure clinic. I think this is Dr. Harikrishnan's question. nurse-led heart failure clinic. I think that's what you've been talking about
Yeah,
all.
that is the way. That is the way forward. I think the physician is only secondary. I think the nurse is the main person who is handling that. So in our clinic, what we do is the nurse initially sees the patient, takes blood pressure, and there is a column for whatever problems they had. They will record. Patient had a recent admission, and our patient had a respiratory infection and was admitted somewhere. Patient had some issue that will be recorded, and patient they had already a conversation, and the nurse comes and tells me that the patient had a recent worsening. Then we will go into and he had stopped drugs or he had a problem in the house, he couldn't buy the medications. Then we will see how can we do it. We will direct them to this what is it? The generic medicine stores, something like that. So all these are all can be done in helping these patients. So that is it. So any other?
I think there's a question on 300 meters, 6-minute walk test. I think, Dr. Babu, I think you should probably tell them how to do this, how to interpret this, the distance, what is going to be all right and what is not all right. Just a few points on that, just a few points.
Yeah.
Don't elaborate too much onto that.
So it's a measurement. The 6-minute walk test that we always use is a measure for the functional capacity, which indicates how much ability they have to carry out their daily activities and their regular function. Heart failure patients, yes, I think you can have varying degrees depending on the severity and the amount of deconditioning that they have. Their amount that they can actually perform varies from as low as 50 meters, some of them even lesser than that, to high functioning heart failure patients who can actually do beyond 400, 500 meters. An important part is normally for us to think about the intensity of exercises. The lower the level, the more slower the progression. But what is important in the monitoring is a decrement in functional capacity. So whatever their baseline was, if in a follow-up period you see that functional capacity has dropped, I think that's a time to alert the cardiologist and say that something is going wrong. And then the patient may need to be evaluated at that stage. So rather than talking about absolute values, I think the changes that you see is quite important.
I think the bottom line is that you are your own judge. Each patient has his own benchmark. Look at how he improves and decreases. The 300 is just a benchmark. I think it's more of a theoretical value. I think you should look at each patient. I think that's the bottom line. Treat each patient individually. There's one question on which is the highest priority: excess fluid volume, sleep pattern, activity. I think it's a redundant question trying to ask which is important: the left hand, the right eye, or the left eye. I think everything is important. I think it should be a comprehensive heart failure program. And I think Dr. Harikrishnan has stressed on all the points. I think I'll skip that and see if there's going to be anything else important. I have more questions on the attendance link, sir.
Yeah, I think they are more concerned about the attendance link. Yeah.
So any update on ejection fraction level in heart failure? So
I think there is something that new concept called improved ejection fraction. That is the one which has recently come. Those patients who had a less than 40% EF who has recently improved to more than 40 or the 10% increase is called heart failure with improved ejection fraction. That doesn't, for example, even if the heart EF has gone from 35 to 60, that doesn't mean the patient has recovered completely. Patient has, this is improved ejection fraction. That doesn't mean that, but they have subtle signs of, if you do a strain imaging and all, they will still have a ventricular dysfunction. And you should never stop the drugs. There was a study called TREND where they have stopped the drugs in such patients and almost 45% of them relapsed with heart failure. So you should never stop the guideline-directed medical therapy in heart failure patients unless you can stop the diuretics probably, but not the guideline-directed therapy. So that is the importance of that.
I think very well said, sir. I think it should be clearly understood that this new concept of improved ejection fraction is seen more often because of good guideline-directed medical therapy, and don't stop the drugs is very, very important. But we're going to have more data on that sooner. I think there are a lot of ongoing studies on that. We'll keep updating you with more studies. So next year, probably when HFA has the next meeting, you should probably attend to listen to more important things on that. And I think this is very subjective. The low blood pressure and continued antihypertensive medication, I think most probably in heart failure, there is going to be a low blood pressure, and symptomatic hypotension we had already mentioned is more important. So I think if there is an issue, I think you should consult a physician if the patient is symptomatic at any point of time. Otherwise, probably reassure a patient. They want a session on ECG interpretation. Probably we could plan one later, sir. And what is the incidence of pediatric congestive heart failure currently? It's a little different question.
I don't know whether there are any pediatric heart failure registries on one way is currently going on, but there is no incidence data. Is very difficult to get because we have to have a community study to get that. So that is very difficult. We don't have any data from India. Then last question is on mid-range, mid-range or mildly reduced ejection fraction. That is the ejection fraction between 41 to 50%. So those patients have the same treatment as heart failure with reduced ejection fraction. So they behave almost the same. So up to 50% EF, we can say that it is the same treatment of the 4 pillars or whatever. So they have a class 1B indication. It is not class 1A, it is a class 1B indication to treat circulation. Because you can practically say that below 50%, it is the same treatment. Practically, we can give it to all patients. More than 50%, what is called the preserved ejection fraction. They don't have the guideline of 4 pillars or something like that. They have 2 or 3 drugs which have been found to be effective. The most commonly used drug is the SGLT2 inhibitors like dapagliflozin and empagliflozin, which is found to be effective. Other drugs are coming up.
There are a few questions in the chat box also. I'll skip a few of them. One on moderate aortic stenosis without heart failure, which I will skip. They want to answer. I think it's a separate question. The next question is on how to escalate GDMT to target dose. I think you clearly explained that already. Look at the patient, look at the hemodynamics, and go slow. Try to get all 4 drugs on board is more important than trying to get a full dose of one drug. Something about antibiotic resistant infections and rheumatism, I think we'll skip that. And in a patient on DAPA, metoprolol, and sacubitril valsartan, what is the cutoff heart rate and blood pressure? Probably you might tell a word about what is going to be the ideal heart rate, which I think will be more useful than the blood pressure. We have already mentioned about symptomatic hypertension on that, sir.
Yeah, I think heart rate should be, our target heart rate should be around 60. That should be the target heart rate. So some patients will have a heart rate of 50 to 60. That is fine. So 50 to 60 should be a good rate to maintain. And if the patient is on a full dose of beta blocker, if the heart rate is more than 70, you can consider adding ivabradine. That is one recommendation. And the thing is that the patient is not, if the heart rate is, for example, 48, and the patient is totally asymptomatic, no giddiness, then I don't think, especially in the early morning hours, you need not bother about that. I think that is not of any concern. If the patient is in sinus rhythm, you should get an ECG and confirm. Patient is sinus rhythm, patient is symptomatic, no need to be worried about that. And about the blood pressure, I think many of the patients will have a blood pressure of 90 by 60, many of our patients. So that is what Dr. Prabhakar was mentioning repeatedly, that symptomatic hypotension. That is the key word. And one more thing you have to see is the postural fall in blood pressure. If the patient is complaining that the most important complaining is getting up from a sitting position, you feel giddy. That is the patient you have to look for. Many of the patients with heart failure will have this symptom. So do a postural blood pressure. So take the blood pressure at baseline after significant, whatever the recommended 5 to 10 minutes of rest. You take the blood pressure in the sitting position, ask the patient to stand, do the blood pressure at 1 minute and 3 minutes. If the blood pressure drops more than 20 systolic, don't bother about the diastolic. You just see the systolic blood pressure. If it drops more than 20 with symptoms, patient feel giddy, that patient has postural hypotension. Then that patient, you should be very careful in increasing the dose of especially ARNI or ACE inhibitor or ARB. That should be very, very clear. So that patient will have a problem. And sometimes you may have to reduce this patient already on this. For example, they are taking 200 milligram BD of ARNI. Patient complaining of this symptom, you documented a postural fall in blood pressure, then you have to reduce the dose of ARNI or ACE inhibitor or AR. That is also very important.
I think that's a very good explanation for postural hypotension, sir, because there the diuretic dosage also has to be adjusted. Fluid is probably underhydrated. I think a lot of things have to be done. It's better to consult your doctor. Don't try to manage it on your own. I think that's very important because a lot of things involved in that. That's important. There's a question from cardiothoracic ICU patient getting arrested. I think you should talk to your surgeon about it. I don't want to talk about it. It's a little tricky. And there's one interesting question about market available lozenges that can be recommended for patients with fluid restriction. I think
I think you
the
can.
thirst is more of a craving for underhydration. Whether you should give lozenges, I'm not very sure. Your comment on that, sir.
I think you can give a small, volume of fluid. I don't think 20 or 30 ml of fluid will make a lot of difference in patients, even though these patients are admitted. I don't know whether you should spend money on these lozenges. You can give a small amount of fluid because because now there are studies which shows that thirst-directed fluid intake is equally beneficial. So you need not restrict fluid so much in patients. That is what.
I think we have finished we have come to the end of all the questions. I've tried to answer all the last few questions. There are more questions on your exams and other things which I've skipped.
I think they are very concerned about the exam. I think don't worry about the exam. I think we have already answered. If you heard my talk properly, I think 90% of the answers are there in that talk.
So is there a timeline for finishing the exam, sir? Or you can
I think we have
put
given
them
that
through again and do it again?
the forms will be available for almost a week. They have already posted the post-test link is already posted by Vinay. Vinay is our person who is doing this program. I think thanks to him, wonderful arrangements. They have sent so many reminders, multiple reminders, and they have Vinay has done this form. It's not the pre-test; it's a post-test link. Why do you want to do pre-test? The post-test link is available. Link will work. So I have personally checked it. It is working, and I have answered the questions. And there were some minor mistakes which I have done.
One last question on fluid requirement is required for patient with heart failure per hour. I think it's not like that. I think it's an individualized question, but generally about 1.5 liters is fair enough for anybody with heart failure. So it all depends on your heart failure, your sodium, and other things. So generally about 1.5 liters is good enough for everybody. So I think that should
what you can do is you can if patient is admitted in the acute setting, you can do a urinary sport sodium, and based on that you can give the fluid. And that is what it depends. You cannot have it depends on the value, and the patient is not responding. Then you have to increase the diuretics and see if the patient brings out adequate amount of urine.
Wonderful. I think this cardiac rehabilitation course that Dr. Abraham Babu has been telling about has also been a very good source for patients or all the sisters to get a certification and learn more about cardiac rehabilitation. It's a very good field. And this nurses certification course, I think we'll probably have an update next year, sir. I think more people should join in. A lot of people have given him. I had a couple of feedbacks directly saying, you're giving a talk tomorrow. What are you going to talk on? I said, how was it so far? And they've all been very impressed with all the science that has gone in and everything that they have learned so far. And I
am happy that, I am happy that 545 people in this Zoom platform are attending this program, and we have a significant number of the YouTube channel also, because we didn't have that much capacity in the Zoom. So we have to opt for a YouTube channel. So significant numbers in the YouTube channel also. So I think Abraham will have too much work to do, because so many people are asking for your cardiac rehab program. I think you will be overwhelmed by the registrations, but I think it will be good, because we are coming out with the heart failure rehab because under the leadership of Abraham and the Manipal Hospital. We are coming out with a rehab program for our country. So that is a heart failure rehab program. We are publishing it.
One suggestion there. I think we should have a dedicated issue on cardiac rehabilitation.
Yeah, that is what we have already planned. I think January to April issue of Heart Failure Journal of India will be on pediatric, on rehab. It's already there. Abraham is leading that.
The flyers are the flyer is out on social media today, I think, so it will be going around.
You send me I run the HFA social media, so I think I'll probably put it there also. Great. I think it's
it's,
wonderful, sir. I think if there are no further questions, I think Dr. Harikishan sir can close the meeting.
So thank you everyone for it is I think it is hope you all of you have got the post-test link. If you have not got, it will be posted in the WhatsApp group and it will be available in your emails also. I think some people have difficulty in opening the link that we will it will work. I have already checked it 2-3 times. It is working well. So there may be some issue with your system. I think Vinay and group will be always be there to help you out. Once you complete, and you will get the certificate within 1 or 2 weeks. So give us time for 1 or 2 weeks. We will give the correct email also. The email should be correct. Then only it will be the things will be sent to you. Okay. So you will get the certificate. If you have any issue, keep us posted. So the form is available, and Abraham has posted the call for paper for the heart failure rehab issue. So I think we are already reaching the time. It is 8:55. I think it's time to wind up. So from all of us in the Heart Failure Association of India, and I thank Trained Nurses Association of India, Miss Annie Kumar and Evelyn Kannan and Roy Joseph. These are the 3 people who are the pillars of Trained Nurses Association of India, who have helped us in the program. They are stuck in Mumbai for their conference. That is why these office bearers of TNI could not join. They have agreed, but they were traveling and they are probably in the flight coming back. So that may be the reason. So once again, thanking you all for joining, and especially Trained Nurses Association of India, the Sumida of Heart Failure Association, who is running behind all the hard work, and Vinay and team Hallmark from Bangalore, who is doing the Zoom link and the projection and the post test. So thank you so much. And next year also we will be running a program, and we will be initiating a heart failure nurses course with the support of either mostly with Heart Failure Association of the European Society of Cardiology. We already had a discussion. I think probably within a few months we will starting a program with the support of they have a very well organized heart failure nurses program. So we will have more organized training with them. So that is our plan. So thanks everyone, and good night. And please take the post test. If you have any issues, please contact in the email provided. Thank you and bye.
Thank you. Good night. Bye-bye.
Thank
Bye
you.
bye. Bye.